going to share my presentation now. Are we okay with it?
Okay, doctor.
Okay. Our topic today will be on the oral cancer detection. What is the central role of general dentist? My lecture will be completely focused and directed to the role of general dentists, not for specialists. I will try to make it easy. I don't know, I have a problem in the slide. I should not do it with a slideshow or what? Okay. Among the discipline of general dentistry, we are overwhelmed with the operative work, the endodontic work, maybe the ortho, maybe the orthodontics, endodontics, surgery, and so on. So where does the role of you as general dentist in detecting or identifying oral cancers? Why do we tend to lose this interest about this important role of you as general dentist? So let's go for some statistics, some numbers, to make it clear why do we have this topic today. The prevalence of oral cancers worldwide. You can see here the map of the world. And if we focus on our area here, okay, this is a World Health Organization statistics. We have a great incidence, maybe the middle part. For the mouth cancer or oral cancer rates, it's increasingly during the last 10 years, especially for men, it's 3 to 32%, and for females, it's 33%. Now, oral cancer is the 10th most common oral cancer among male, 15th among females. Some more prevalences. Where do we stand as Egypt, the oral cancer world rank? We are the 142 among the world. Not so good, but it's still not so bad. Oral cancer percentages. In Egypt, of course, this through the World Health Organization statistics. We don't have yet in Egypt a recent survey for oral cancers. What are the numbers of oral cancer death worldwide? Still in Egypt, it's not so good, but not so bad. Okay. Let's talk more about mortality. And here I'm talking about survival, 5 years survival rates. This is very important number. I would like you to give attention to. We are identifying or diagnosing new cases, early diagnosis of oral cancer, the survival rate will be less than 50%. But if we are late diagnosing these oral cancers, for the advanced cases, it's less than 50%. But for the early diagnosis, it will raise to an 80% survival. So you're increasing the survival rate for your patients. If we are comparing this with most common cancers worldwide, like breast cancer, it's 75%. So early diagnosis will increase the chances of your patients in survival. So what are the role of you as general dentists in this area? Are you requested to treat? No. Are you requested to do advanced imaging or advancing biomarkers or things like this? No. It's really very simple and very preliminary. First of all, a disease risk assessment. You need to know who are the risk people, what are the risk factors for your patients, for you to identify. Then, the second important role is to early detect and do the preliminary diagnostic steps. For patients, who are the risk factors, or what are the risk factors for patients? Is your patient one of those high risk factors people? Let's see. Smoking, top of it. Alcohol consumptions. Some people are using the smokeless butternut or smokeless tobacco chewing. The habit of reverse smoking. Sun rays, especially for the white complexion people, is one of the risk factors for actinic colitis or the cancer lip. Tobacco forms, because most of our patients thinks that smoking is like the only one is like cigarette smoking, but it's many different kinds of smoking. Cigarette smoking, shisha smoking, pipe smoking, those who uses the leaves or the powders or whatever, using it for topical applications. The new era of females smoking shisha and so on, especially in our Arabian countries and Egypt. You can go and read all about the danger, the poison, the toxic material, the byproducts of nicotine. For us to say, for people, for patients, you need to stop smoking, you need to cease smoking. Okay, if we have a patient who is using cigarette or who is smoking cigarettes, what are the lesions that we are expecting to see? Smokers, melanosis, the leukodema, smokers patches. If you look on the hard palate, you may see this white hyperkeratotic lesions and what we call stomatitis nicotina, which is the red dot of the hard palate. For those who are using pipe or cigars, still you can see this kind of stomatitis nicotina on the hard palate. For those who are using the pipe, also you can see the lesions, the white lesions, somehow looks like white leukoplakias on the lower vestibule. For reverse smoking habit, it's not that common in Egypt, but have seen it while I was working in Saudi Arabia. Still, you can see it on patients who are using the shisha. The lesions on the hard palate becomes much more exaggerated, much more hyperkeratotic. Okay, those are different kinds of ways to use the tobacco chewing or the butternut. Still not that common in Egypt, but we have seen cases such like this, especially for people who have lived some of their time abroad, or of course we have many of our Arabic guests living in Egypt. You can see this many in Yemen, some of the Saudis, some of even here in Egypt, in people who are living in the Rosh sites, maybe Sinai and Arish and things like this. Okay, these are other kinds of smokeless preparations. What lesions can we expect to see in here? It's especially related to the site where the patient is using or is putting the preparation. Some of them are using it on the buccal mucosa, and some of them are dipping it on the vestibule, and it's called the betel nut or oral snuff preparation. Alcohol consumption, still not that common. I don't know, maybe it's common in Egypt, but what is the risk of alcohol consumption? When it's combined with smoking, it doubles the risk of oral cancer potential. Okay. For minor risk factors, which are reported in the literature, viral infection, especially human papillomavirus, is commonly linked to the cancers of cervix. For us, herpes simplex viral infections. Okay, for immunocompromised patients, also increased risk of having cancers, some genetic predispositions, some dietary factors, the diet of the patient, chronic inflammation, diseases, and other infections, poor or bad or oral hygiene. Nutrition defects, you need to ask your patient about the normal diet he is using and encourage the patient to eat as fresh vegetables as they can, vegetables or fruits as fresh as and because it's heavy with trace elements. Iron is also needed. I have mentioned the relation of trauma or the inflammation. We have seen some cases of oral cancers and malignancies related to a chronic or a long use of dentures. Underneath the dentures, it's from, maybe it's somehow the reaction of the oral mucosa to the chronic irritation of a denture. Okay. So what should we do? High risk group or high risk patients, for those we have just discussed, they should be carefully screened and followed up. And let me tell you, oral cancer screening as the steps of examination and doing the necessary investigations for patients has become a primary importance for all patients. Especially if you have a high-risk patient, this group that we have already discussed, you need to carefully screen and carefully examine your patients. How? Okay, so early detection is very, very important for the better prognosis. We have already mentioned the mortality rate, the survival rate of patients that is increasing with early detection. And we need to mention here for early detection that patients don't come seek for treatment or come seek for until late, because the oral cancer and most of the cancers are like silent killers. They are very sneaky. They are usually don't manifest like pain or any manifestations that would bother your patient. So he will come already somehow late. So you need to do your work as early, examining as much as you can. So your clinical examination, as in thorough clinical examination, will be adjunct with some simple chairside diagnostic aids we will mention soon. Conventional oral examination is a key for all investigations. It's a key for all general practitioners, for all dentists should be followed. Here for in this diagram is how you should do your clinical examination as the routine clinical examination, examining the lips and gingiva, the buccal mucosa, the vestibule, the buccal mucosa, the tongue, dorsals, lateral sides, ventral surface of the tongue, and of course, don't forget about the tonsils and the pharynx, of course, the hard palate. So you have to go through all the mucous membranes covering the oral cavity. Don't forget to examine the lymph nodes related to the head and neck. All the categories of lymph nodes need to know that for malignancy, the lymph node will be felt like a fixed lymph node, matted somehow, attached to the underlying mucosa. This would make you more worry about the condition of the patient. Okay, so where are the risk sites in the oral cavity? what are the clinical forms that should suspect your mind, and what are the potentially malignant lesions. Risk sides, this is the oral cavity I have already mentioned in the oral examination. Lateral sides of the tongue, posterior part of the buccal mucosa, floor of the mouth, and soft palate are the most important risk sites in the oral cavity. Proper careful examination of risk site is a must. Okay. Clinical forms, I've just mentioned the word sneaky lesion. So oral cancer is like a magician. It can wear any kind of presentation. You can see ulcerations, you can see erythroplakias, leukoplakias, red lesions, white lesions, induration. You can see bleeding, you can see exophytic lesions, you can see necrosis. So it's not always ulcers like we all think. No, you may see different kind of lesions. Among all the oral cancers in the oral cavity, squamous cell carcinoma is the most common one. It's like 80% of oral cancers. As I was just mentioning, you can see different kind of presentation: figurated swelling, ulcers, granulations, variegated lesions, exophytic lesions, bloody crusted lesions, especially on the lower lip. Also, you can see as innocent as white lesion, pure red lesions, or a mixed red and white lesion that doesn't look like an ulcer. Verrucous carcinomas, sarcomas, those are a different kind of cancers, not oral squamous cell carcinomas, of course. Adenocarcinomas of the salivary glands, malignant melanomas, and lymphomas, all are different kind of cancers, along with, of course, the malignant lesions of the bony lesions of the jaw. Not only squamous cell carcinoma. We are focusing on squamous cell carcinoma because it represents like 80% of the oral cancers. What are the potentially malignant disorders that you should give your attention to? Leukoplakias, erythroplakias, and leukoplakias is the white lesions that you may see on the ventral surface of the tongue or the lateral surface of the tongue. It's a pure leathery white lesion. See it here in the floor of the mouth and the ventral surface of the tongue. You can see it as variegated lesions as well. Verrucous leukoplakias or spicate leukoplakia is in here. Oral lichen planus, which is a white mucocutaneous lesion, you may frequently see, has reports with increased incidence of oral squamous carcinoma. You can see it as a red lesion as well. Mixed red and white lesions. Different kinds of oral lichen planus. Actinic cheilitis or actinic keratosis on the lower lip, you may see it as a white lesion, you may see it as a mixed lesion, and also you can see it as an ulcer, as a crust. Okay? Remember, the various clinical appearance of oral cancers, malignancy never start without a pre-malignant lesion. This is a very important note for you, because at that stage it's reversible. You can reverse the condition as early as if you see the patient in the pre-malignant condition. Don't overlook the pure innocent looking lesion. It's a suspicious. You see something that is not normal, it's an abnormal lesion, and you should go for more investigation. I will go through fast with the new oral cancer detecting system that helps us in identifying those suspicious lesions. We have the vital tissue staining, the toluidine blue test, or the ORA test. It stains the lesions with a blue color for us to identify or to take our biopsies. Also, the light-based detection system, different kind of, this one, the busy light, is a chemiluminescence where you can see the lesion more profound. It facilitates you identify the lesion with the light-based technique. Okay, it's very easy to use. This stick, you just break it and it will turn into a light. You can use it to see the oral lesions like this. It's also adjunct with the toluidine blue test. Microlux DL is another machine or tube or device. You can use it, but it's battery, and you can use it for many patients. Still adjunct with the toluidine blue test. There is a Veloscope, which is an autofluorescence technique. It's يعني شوية heavy in handling. You can see it as a green or green amber يعني color. You can see it for the normal lesions, for the squamous cell carcinomas or the pre-malignant lesions. You can see it dark. Okay, like this. Also, the Adintafi 3000 is this يعني a more useful tool to use. Not heavy in handling like the Veloscope. It's easy. It's slightly expensive. And these are the saliva-based diagnostic tools for, of course, those are for investigations, for more research work, not for use in the general dentistry clinics. I would say the biopsy is still the gold standard for diagnosis of malignancy. Toluidine blue is an effective adjunct to choose the site of biopsy. A biopsy will give us a final diagnosis for the lesion. It will tell us if the lesion is a squamous cell carcinoma, if the lesion is a melanocytoma, if the lesion is any kind of cancers. It will be known as definitely diagnosed with a biopsy. We may mention biopsy as cytology. It's a non-invasive screening technique, and it's very easy, and it can be used as a chair side test. I have the privilege that I have published 2 papers related to those light-based adjunctive tools. You can go and read them if you would like to know more about this. Always remember, don't forget, take home message. Pre-malignant lesions are those suspicious lesions. Malignant lesions never appear suddenly. It's always after pre-malignant lesions. At that point, it's reversible. Don't get to be fooled with the innocent look of some innocent lesions. They may be pre-malignant lesions. So consider them are suspicious lesions. Don't forget to do your clinical examination, both oral and lymph node examination. Don't forget your patient education about the risk factors and the diet and the importance of early detection and any change of behavior of any lesions. Then you may refer to a specialist for further investigation. I hope that I didn't bore you with my presentation, and thank you all.
Thanks, Dr. Suzan, for such valuable, fruitful lecture and the presentation. Really, it's a great pleasure to host you today in our first dental conference, DIDC 2020. Thank you.
You're welcome.
Dear guests and attendees, the fourth lecture will be held after 10 minutes with Professor Dr. Iman Magdi under the title of The Use of Platelet Concentration in Treating Oral Mucosal Ulcers. Please keep in touch and don't go away.
Thank you.
Thank you, Dr. Suzan. Thank you.